palliative care at Bonheur Hospital in Memphis, Tennessee, the pediatric hospital there. She's also Associate Professor of Pediatrics at University of Tennessee Medical School. Before I go any further, though, I do want to ask everybody to give another round of applause to Dr. Bud Hammis for coming down. We're honored to have him, as we are Dr. Cunningham. Dr. Cunningham graduated from University of Massachusetts Medical School, where she also did an internship and residency in pediatrics, as well as a fellowship in pediatric hematology, oncology, and transfusion medicine. She was assistant professor of pediatrics at Harvard Medical School, where she also did a clinical fellowship in pediatrics and pathology. And she spent time as the program director for the American Society of Hematology Health Volunteers in Uganda. And currently, she serves also on the ethics committee at Bonheur Hospital.
He's now saying what I like to hear, so I moved in.
The communication task force there, the faculty affairs committee, patient advisory council, and she reviews grants for the CDC with regard to research in bleeding disorders. So please all welcome me join me in welcoming Dr. Cunningham.
Thank you very much for that introduction. And I do just have to say that UMass doesn't have a pediatric hematology oncology fellowship. It's actually at Boston Children's and Dana-Farber Cancer Institute. So I was out in the western part of Mass and then moved into the city. So I would like to talk, and really the topic probably should have been pediatric palliative care and post, practical approaches, potential pitfalls, and poignant moments. Because I think in my role as the palliative care director, the lead-in to discussions regarding resuscitation status for patients or post forms for patients, and it's usually I'm having discussions with the families based on my patient population, starts with the palliative care consult. And so it's a little bit different paradigm, I think. My disclosures, I have no financial disclosures, no off-label uses of medications, and for the 2 patient photos I have approval. Oh, so
that's the recording.
Oh, excuse me. Are we okay? Do you want me to start over? We're good, okay. All right, so a definition of pediatric palliative care is really helping children live as well as possible for as long as possible. And I think that this is, again, a little bit different paradigm in pediatrics than it is in adult medicine. Having just studied for the palliative care boards, which about 90% of it is adult medicine, I had to learn about some of the information we have really on prognosis for advanced dementia, for COPD, for heart failure. And in those diseases, we have a more clear understanding of prognosis. I would argue that in pediatrics, we often have murkier ideas about prognosis and about longevity. And so really, for as long as possible, may really be much longer than we or the families expect that to be. So what are some of the practical approaches from the standpoint of the background of palliative care in pediatrics? And hopefully some of this will help to set the stage for understanding for those of you out there who don't deal with pediatrics, and I'm assuming that's the majority. Are there any, besides the resident that I brought with me from Bonheur, are there any folks out there that deal in pediatrics? Other than their own families. Okay, so we have some American Academy of Pediatrics guidance. I want to talk about a sentinel study, a little bit more about disease trajectory and prognosis, and then relationship with families and with patients, and then the approach without relationship. So I came from being a pediatric hematologist, oncologist, and knowing my patients from the diagnosis to either cure or death. And I thought when I took this position at Bonheur, how was I going to deal with helping people in difficult situations when I didn't have that long-formed relationship? And so I'll talk a little bit about that approach. So what about the AAP? What's their policy statement? And this is their policy statement on pediatric palliative care, that it ought to enhance quality of life in ultimately terminal conditions, provide relief of symptoms, particularly dyspnea and pain, but certainly others, relief from conditions such as loneliness and fear, and also to provide bereavement to ensure or try to ensure that the family can remain intact after the death of their child if the child does ultimately die in a situation of a serious illness. They also propose an integrated model. It's the components of palliative care they suggest should be offered at diagnosis and continued through the course of the illness, whether the outcome ends in cure or in death. So that's a lovely and I think utopian paradigm at this point, because we don't have enough people who are in the specialty of palliative care, pediatric palliative care, to provide this. And then I would argue, and I think that Dr. Hammes would agree, we haven't trained our subspecialists and our primary care physicians well enough in palliative care in order for that to be provided. And we had this discussion over, I think, dinner last night, that we think of palliative care, it's this new buzzword, it's this new subspecialty, but really in my mind, much of it is good old-fashioned family-centered medicine that really focuses on families' goals of care, understanding the adults or the children and their what defines quality of life for them and for their families, and then really excellent symptom management. And I would hope that at some point, perhaps palliative care was really a subspecialty that dealt with very complicated symptom management, and that the rest of it would really be a continuum provided by the either primary care physicians or the primary subspecialists. But that's a little of my soapbox and dream. So here's a sentinel study that I think is really important in helping us to dispel some of the, if we talk about palliative care being involved and discussions about goals, being involved from the get-go at diagnosis to either cure or death. We need to get rid of the myth that many clinicians and parents and families carry, that palliative care is only about is equivalent to hospice care and is only about end of life, and that would actually shorten rather than lengthen life. So this was a study that, it was an adult study looking at early palliative care for patients with metastatic non-cell lung cancer. There were 151 patients. It was a randomized prospective study, and they looked at standard oncologic care only or standard oncologic care with early integration of palliative care. They did baseline and 12-week assessments and looked at a variety of things, but particularly decisions and quality of life. In the results, 107 completed assessments, and some of the things that we who do palliative care say are no-brainers. Certainly these patients had better quality of life, and a higher number meant improved quality of life, and that was statistically significant with a p-value of 0.03. Less depression, again, a significant p-value. Less aggressive end-of-life care, also statistically significant at 0.05. But I think the surprising thing, and the thing that really turned people on end, was that these patients had longer median survival, and that was also statistically significant. So when people say, oh, well, I don't want palliative care involved, or I don't want hospice involved, they often have the misconception that this is going to shorten things. And really, this study and some subsequent studies have shown that it can lengthen life. And I have an adult palliative care doc who some of you may know, Clay Jackson, he's one of my colleagues in Memphis, who philosophically puts it that if one has a certain amount of energy left to live, if you spend that energy fighting dyspnea or fighting pain, then you don't have that energy left to live and enjoy quality. So what are some unique aspects in pediatric decision-making that inform the discussions and the decision-making? Well, the causes of death in children are different than the causes of death in adults. Am I still not doing things correctly?
Yeah, a little bit louder.
Okay. So I haven't told any jokes yet, so it's not that you didn't laugh because you couldn't hear them or that they weren't funny. Okay, so unique aspects that inform our discussions and our decisions. The causes of death in children are very different than the causes of death in adults, and we'll talk a little bit about illness trajectories and prognosis. So you can see here, and now I'm really going to go off. Can you hear me? Okay. The causes of death in children are, again, very different than adults. So unintentional injuries, homicide, suicide, and other. And you'll see that cancer, death from cancer in pediatrics is only in 4% of the deaths in children. And I think most people, when they think of pediatric palliative care or pediatric hospice or pediatric death, think that cancer actually predominates. But you can see that there are many other all right, take 4. That there are certainly many other causes of death in children. And because in Memphis, the oncology patients are primarily treated at St. Jude, we occasionally see them at Bonheur when they come for their neurosurgical interventions. The majority of patients that we take care of on our palliative care team at Bonheur are these other patients. So patients with short gestation who are in the NICU, patients with complications of pregnancy or in utero genetic diagnoses, heart disease, congenital anomalies. Many of our patients have severe developmental delay and cerebral palsy. That's really the majority of patients that we take care of. So very different from my days in oncology, working with patients that can really help us to decide what their wishes are, what their quality of life means to them. Many of these patients are not verbal and have not been able to develop enough to do things even to give their families proxy of what might be important to them from the standpoint of quality of life. So then they're really making decisions without having had a discussion, without having the information that makes it easier, never easy, but easier to make decisions for someone else. So what about the illness trajectories and prognoses? So there are certainly variations in cause of death and prognoses, and really 4 basic trajectories exist, and the timeline can often vary. But if we look at these graphs, here is health status, similar to the one that Dr. Hammes showed. And this is a situation where a patient has really 100% normal health. And here's our timeline to death. And there are certainly situations where there's sudden death from unexpected causes, SIDS, unintentional injury or homicide. And occasionally we get involved with these patients and help families make decisions because they might not die immediately but have a significant neurologic injury from these unintended injuries. Excuse me. Then we have patients who have illness with risk for life-threatening events. So their health status at baseline is a little bit lower than a patient who has no health issues. These may be patients with a significant seizure disorder, a neuromuscular disorder, and they may have a complication that leads to sudden death or a sudden ICU admission with much worsened clinical status, significant neurologic devastation due to perhaps status epilepticus or a very severe aspiration pneumonia, for example, in a patient who has neuromuscular disorder. And then we have ones where we have a little bit better idea of the trajectory towards death and decline from progressive disease. So something like a brainstem glioma or a mucopolysaccharidosis, say that one 4 times fast. But it's basically a storage disease where the patient lacks the enzyme, those non-broken down proteins end up in the organs, and ultimately those patients die. And we have a little bit better understanding of the timeline to death in those patients. And then we have patients who have advanced illness and a slow decline with periodic crises, be they hospitalizations, be they ICU admissions, be they just changes in what the patient is able to do. And at these crisis points, if these crisis points occur in the hospital or their ICU admissions, we'll talk a little bit more about this later, but I think we set families up for not fully understanding the trajectory that their child or their adult parent is on if the clinicians are too dogmatic about what they think is going to happen. Because I can't tell you how many times we've heard, well, I've been told my child wasn't going to live for 6 months. I've been told my child was going to die 4 hospital admissions ago, and they didn't. And so I think it's important, and I'll talk a little bit more about that later in terms of pitfalls. So we certainly need to provide family and patient-centered care. And some people say, well, how do you deal with the parents? And certainly, sometimes you do feel, dear me, what a troublesome business a family is, because it certainly complicates things. It complicates discussions, especially when there's a very extended family involved. But I would say that that's where, I think that's where the uniqueness in pediatrics comes, and I think that's also where we have a great role to help these families, these parents who are making decisions without their child's input in many situations, not have significant moral distress with the decision and not have long-term complicated grief. So I'll talk a bit more about that later as well. So what do I mean patient and family-centered care? It's not turning over the decision-making to the family, but it is often thinking outside of the box. So I love this cartoon, and in fact, they make a mug, a coffee mug that has this cartoon. Never ever think outside of the box when you've got your kitten by your litter box. But certainly in pediatric palliative care, and I think in palliative care in general, we really have license to think outside of the box and really have to think outside of the box. And I have the luxury at Bonheur of having a risk manager. In fact, I gave her this mug because our risk manager is very able to think outside of the box. And she laughs when I repeat her statement, but she says that protocols and policies are for 2 standard deviations beyond the norm. When we get to 3 standard deviations beyond the norm, maybe those really don't apply. And then maybe we have to think about why they don't apply, document why we're doing something that's outside of that norm, and do it if it's the right thing for the patient and the family. So I'll give you a few examples. This was not my patient, but one of my colleagues, before I gave a talk, told me about one of her leukemia patients and laying on of hands. So I think we all think of leukemia as a medical emergency. And certainly in my training, patient diagnosed with leukemia, yep, admit, start the hydration, make sure you alkalize their urine, make sure you they have sufficient platelets, red cells, etc. But really, just like any disease, it can present along a trajectory. So not all patients with leukemia present in extremis. So this, I want to say 2 or 3-year-old patient presented with leukemia. The family said, no, we don't want to be admitted. We want to go home and lay on of hands. And the child wasn't going to fast, but the family was going to fast. And at first blush, you say, well, that's impossible. But looking at the blood counts, looking at the child, there certainly wasn't a medical emergency. The family had a reliable car, had a telephone, and clearly understood the reasons to bring the child back. They went home, fasted, laid on of hands for 2 days, brought the child back. She initiated her therapy and actually did very well with her therapy. But you can imagine the degree of trust that willingness to think outside of the box and think within the family's goals provided in the long term for that relationship. So another is home nasogastric feedings. When I was first at Bonheur, we had a patient who was transferred from Jackson with, I have a lot of long names in my specialty now, alobar holoprosencephaly. So basically a significant midline defect, not very much brain tissue, difficulty with swallowing, and really not, had brain stem function, but not other function. Was transferred from Jackson to have a G-tube placed. Well, an elective G-tube doesn't take very long to put in, but it sure takes long to get you put on the OR schedule, especially when you are a level 1 trauma center. So the surgeons are busy, the OR is busy, and I've seen patients wait for 2 weeks for an elective G-tube. And not by anyone's fault, just by, we prioritize. So this patient came, and I was able to sit down with our team and talk with the family, and their goal was to spend as much time at home as they could with this little baby boy. And so I went to the neonatologist and said, gee whiz, why don't we send them home with the NG feeds? And they said, well, we don't send patients home from the NICU with NG feeds. And so then we had a discussion about why this was different. And it was like a light bulb. It wasn't that they were being rigid, but it just was not in their usual line of thinking as neonatologists. So this child did go home with NG feeds on hospice care and lived for 11 days at home. And I would argue if we had waited for the G-tube, the child might have died in the hospital and certainly would have had less time at home. How about continuous NG feeds? Dr. Bishop and I just received this call as I was driving out here yesterday that we have a patient home who has spinal muscular atrophy. All of those patients have significant reflux and don't do well, can't swallow very well without aspirating, and don't do well with bolus NG feeds because they get reflux and they can aspirate. So this patient is home on continuous NG feeds. And the nurse was told by her medical director on that side, well, we don't have patients on continuous NG feeds because the NG tube could slip out of place and go into the lungs. And so that's why we do bolus feeds, and we check the placement before every bolus feed. Well, we're always weighing risk-benefit ratio, and if the risk of reflux and aspiration with bolus feeds is higher than the risk of the NG tube being moved in a patient who doesn't move very much, so spinal muscular atrophy patients lose really the ability to move, and this patient has lost it very early at 2 months of age, that this is actually the better and the out-of-box solution for that patient. Pain medication for a seizure patient. So I was struggling with a patient who has, again, hypomelanosis of Ito. There are 2 articles when you look in the literature, and the diagnosis doesn't matter as much as the fact that the symptoms are intractable seizures for this patient, despite enormous interventions over her first year and a half of life. We weren't controlling her seizures at home, and I was able to make a home visit. She was seizing persistently, and I thought, well, maybe she's uncomfortable because of this, chronic tonicity from her seizures. And just lo and behold, at that time, serendipity in life, I had received some emails from a palliative care listserv that talked about having surgical procedure for a patient with a slipped femoral head. And when they relieved the pain by doing that surgical procedure, his seizures were much better under control. And I thought, aha, here's a little of my justification for trying this. So we did that and a few other maneuvers, and she certainly is not seizure-free, but survived through her 2nd birthday and now through her Christmas, and we'll see how far that goes. Home extubation, I never would have thought of home extubation, except that I watched a terrific video by some pioneers in pediatric palliative care. And I was in a situation early on at Bonheur where a patient, and I promise I won't be passing out tissues, but it does get uplifting. But in this situation, it was difficult. The mother had had a saddle pulmonary embolus when she was, I think, 7 months pregnant, was brought to the emergency department. They weren't able to resuscitate her. They asked the father if he wanted the child emergently delivered, and they did by C-section, but she was quite neurologically devastated. The father said, well, we need to take her off of the ventilator. I want to bury her with her mom. We don't have the money otherwise. And in this situation, I said, well, let's stop and think about this a minute. I don't want, years down the road for you to say, well, if she'd had a couple of days, would she have been different? And so ultimately they decided to wait until after the mother had been buried and those services were over. And luckily, again, our risk manager and our CEO were quite flexible when I said, I saw that this had happened, and why don't we transfer this patient home, which was 2 hours away, with family members who couldn't come to the hospital because of their own medical issues, and have her admitted to hospice at home so that the medications are available and extubate her at home. And I had the luxury of a very flexible CEO and risk manager, and we were able to take that patient home, had their church family around, all their extended family who weren't able to make it to the hospital, and they were able to be with her when she was extubated, and she died about an hour and a half after we got her home, and we were able to go and stay and be with them. So these are just some of the things that I think sometimes we hear, oh, family-centered care, why don't we just, tell them they have a medical degree and let them make their decisions? I hear that sometimes. I totally disagree with that. But I think these are situations where we're working with them to help them achieve their goals. And I think that that's the real patient and family-centered care. So parents have to make decisions. Well, what do we know about parents making their decisions? This came out of JAMA back in 2000, and it was oncology patients, and much of our research in pediatrics comes from oncology patients. And the question was trying to understand the prognosis among parents of children who died of cancer. And the objective was to assess the association of parents' understanding of prognosis with treatment decisions. And it was a retrospective survey at a university-affiliated children's hospital with 103 parents of children and 42 pediatric oncologists. And if we look at the timeline here, from diagnosis to death, can see that the average duration of the disease was 32.4 months. The physician understanding that the child had no realistic chance of cure was 6.9 months, and the parents 3.5 months. And the results showed that when they did look at the parents' understanding that there was no realistic chance of cure, that it resulted in an earlier hospice discussion, better quality of home care, earlier DNR, less cancer-directed therapy in the last month, and higher likelihood of goal to diminish suffering. And they concluded that there was a delay in parents' recognition of prognosis, and I would say that there was a delay in clinician recognition of prognosis as well. And we do have some data out there that suggests we, as the primary oncologists and primary clinicians, sometimes do have a delay in our understanding, and it may be based in part on our closeness and our own hope that there is still a hope for cure. Earlier recognition emphasizes decreased suffering, and earlier recognition leads to integration of palliative care. So now I want to talk a little bit about post in pediatrics. Of course, this is not a pediatric patient, but his name is Daniel Nathan Reed, and he does not initial anything. So what about some practical approaches to resuscitation discussions or post discussions with families in pediatrics? So certainly we need to develop a relationship if it's not been developed. And as coming in as the palliative care consultant for the first time, I don't have a relationship with those families. I have the luxury over the little over 5 years that I've been doing this, because patients do actually often live longer than is anticipated, know some of my patients for the entire duration of my time there. And so as the trajectory changes or as the cadence of admissions changes, we're having a discussion based on a preformed relationship. But if I don't have a relationship, and I'm often asked by the team, this family, they don't get it, they're in denial, come and sort of get the DNR, and I'll talk about that a little bit in a minute. But I think we really need to discard our own personal or the medical team agenda. Doesn't mean that we discard what they know about prognosis and we don't bring that into the conversation, but we really have to be open to hearing what the child, if it's a verbal child, and in particular in my case, in our team's case, what the family has to say. And I usually start after I introduce myself. I'm usually called in after there's been a significant change and they've had some meetings with the subspecialist. I say, tell me what you've heard. And I particularly say, tell me what you've heard rather than tell me what you understand. Because I think sometimes when we say understand, people think, oh, well, I'm supposed to understand something, and might be a little off-put. So I usually say, tell me what you've heard. Tell me what questions you have now, and what worries you most right now. And this is really as a lead-in to my palliative care consultation. It's not a specific lead-in to discussion about resuscitation or post-form. And even if our team has been called as really advanced care planning or post-form discussion as a primary reason of the consultation, I very, very, very rarely talk about that or bring that up myself in the first meeting, because I think unless things are imminently changing, it's unnecessary, and in my experience, doesn't lead to having a collaborative and trusting relationship with the family. Not always, but that's been my experience. And then in terms of being family-centered and patient-centered, as I told you, many of my patients, the patients that our team sees, are nonverbal. And maybe 15, but may really do very, very little to interact with the world. I always acknowledge the child, go and introduce myself to the child, make some comment on how the child looks, something about the child. I think it's critically important. Very often, these families feel that their child is not acknowledged as a human, and so I think that's key to providing family and patient-centered care in my situation. Engage in discussion of what the family likes, what brings joy to the child, what's the child's meaning within the family. And it's amazing that I've gone into some meetings and I have the luxury of being able to spend the 60 minutes or the 90 minutes. I get to rearrange my day based on prioritizing my time fairly independently. Went in with a couple of residents who knew this family actually for quite a few years, and I had not met this family. We went in to talk with them and sat down. They ended up showing us videos of their child when she was a little more nimble, told us about things she liked, showed us lots of pictures, and they turned to me afterwards when we left and said, we've never had a discussion with a family like that, and it really is that luxury of time. And I think in the pediatric world, we have more of that luxury of time than we do in the adult world, just sheer numbers. We have that in oncology, we certainly have it in palliative care. Our numbers are different, and so we're blessed with that. Communication. Always, always, always sit. So I come from the Northeast, and I say we're not quite as polite as they are in the South, and so we go into family meetings, and if there are other residents or other staff, they'll say, no, you sit, I'll stand. And I say, no, in my meetings, everybody sits. There's nobody sort of looming in the corner, because I think it distracts from the discussion. And you probably all know this study, but there was a study done in an outpatient clinic that if the clinician came into the clinic room and sat, it was perceived by the family that the physician had spent more time with the family when the time was exactly the same. So I think that besides setting the stage for people being comfortable, I think that it's important. And if you can sit at least at their level or lower, I think that's important too. Our ICU used to have these very convenient footstools, and I would always bring those in and sit down on the footstool so I was a little bit lower than the family, because I think it sets the stage that, yes, I'm the physician, but we're having an equal conversation. So what are some of the potential pitfalls? I'll run through each of these, but we can certainly have pitfalls in our communication, unacknowledged prognostic uncertainty, post and hospital DNR, we'll talk a little bit about that, unrecognized consequences, and parental guilt. And I didn't make a separate slide of this, so I'll speak to it just briefly here, but they're making decisions based on the what they would understand the child to perceive as quality of life, and based on the child's experience. And as I explained a little bit earlier, many of our patients have not had a robust life where the family has been able to define, if he's not out playing football and doing active things, he's really miserable. They often in our situation have not been able to be guided by those previous experiences. So what about communication? So this is where I do get on a little bit of a soapbox, and as you probably all know, this is a photo of the bomb over Hiroshima, which I used to think was Hiroshima until I got to go to Japan and been corrected. But I put this up here because I think our words are incredibly powerful, and I think they resonate for a really long time. In addition, there's some historical evidence that perhaps the word that was chosen by the Japanese emperor when he received the Potsdam Declaration from, I'm going to show my ignorance, Churchill, Truman, somebody else. I thought someone was helping me. So it's called the Great Makusatsu Mistake, and this was, it's been speculated by historians that this word makusatsu can really mean kind of in your face, I'm not going to pay any attention to you, or it can mean that another nuance, I'm thinking about it and I'll get back to you. Well, the claim is that the leaders who were deciding about dropping the bomb thought it was in your face, we're never going to negotiate, and that the emperor really meant, I need to think about this, and thus the bomb was dropped. I'm not a historian. I know that this is some speculation out there, but I think it speaks to the fact that communication and word choice and nuances can be very important. So if it's so important, how do we train people? We've talked about this a bit already. This is again from oncology fellows. How did they learn to care for dying children? Trial and error, 92%. It was reported by the physicians to be most useful. Well, certainly we all remember our mistakes very vividly. From colleagues in clinical practice, 82%, from role models during residency and fellowship, and then formal courses, only 10%. So very limited in terms of formal courses. Now this was published back in 2001. I think that we've gotten better at utilizing formal courses and role play, but not, certainly not perfect. What about communication training in resuscitation discussions? And this was just published in 2013 in JAMA Peds. During medical school or nursing school, 83% said they had little or no structured training in resuscitation discussions. During postgraduate training or orientation, 44% had little or no, and after completion of training, 51% said little or no. So we know that this is important, but we don't train our staff very well in this. So I have an idea that there are certain words that really ought to be off limits. So I call this lose that lexicon. We hear people say, I'm going to get the DNR, or I'm going to get the post, or go get the DNR. And generally when I do this, I will look at a young man in the audience when I'm talking to the residents or the medical students and say, you know, I'm going to get you to love me. And then I just stop. They look sort of horrified. But I think it drives the point home that our word choice is really important, and it drives our thinking. So if I'm going to go get the DNR or go get the post form filled out, it's very different than saying, I'm going to go talk to this family about their goals of care, what their resuscitation wishes would be for their child. Ethical, I actually heard someone say it would be unethical to resuscitate your child. And I think unless parents are sociopaths, all parents are making ethical decisions for their children. They may be very different than my decisions would be or your decisions would be, but they're ethical decisions. And it was a translated discussion from English to Spanish through the Spanish interpreter. Mom was bilingual, so mom's face went blank and shut down more quickly than dad's, and as soon as the translator translated, dad's shut down. So that's certainly a word to stay away from. Excuse. I think when we say, what was her excuse for not bringing her child to the clinic appointment versus what was the reason, it says something very different about our thinking. You've all heard this before, everything versus nothing. We never do nothing, and we never withdraw care. And I still find myself once in a while falling into that pitfall, and if you look in the literature, you'll see that they still write withdrawal of care, but it's really, we never withdraw care. We withdraw life-sustaining support, we withdraw a ventilator, but we're always caring. And then, to other words, I understand. I think realistically, if we've never walked through someone's shoes, we can't understand. And saying it, I think, can be a bit off-putting, because you might have someone say, well, how can you possibly understand? And then causing suffering. I think that we use the word suffering in medicine a little bit like a sword. If you've ever been in the ICU and understand that the staff feel like it's time to stop the aggressive treatment or stop the ventilator, and I'll hear them say, well, how long will are you going to have your child suffer? Versus being in the exact same situation on a ventilator, opioid drip, benzodiazepine drip, and we assure parents, your child's not suffering, we've got them on medications. And I think we really do use it as a sword, and so we have to be cognizant about manipulating our words to try to get families to do what we want. And I hope you're finding this relevant to post discussions, but I think, for me, I think they're important pieces. So biggest thing I think in communication is listening. I assure you that we can pick up more information when you are listening than when you are talking. So E.B. White also wrote Charlotte's Web. This is from The Trumpet of the Swan. When we go into discussions, and I have folks who aren't in the hot seat, as I say, when there's a bit of silence in the discussion, time it. It's going to be really short, especially if there are lots of people in the care conference. You can often see that the families are either ready to emote or taking a breath in, ready to say something, ask a question, express an opinion, and our anxiety, I would argue, has us bowl right over that. So I think listening is one of the most important parts of communication. So what about unacknowledged prognostic uncertainty? In these situations where there are multiple crises, we very often hear that your child's not going to survive. And when parents hear this over and over again, and I'm sure when adults hear this about their loved family member over and over again in a very dogmatic way, it's hard for them when it comes to a different point to understand that we're at a different point, particularly if the clinicians are different throughout that time. So we very often have a high rotation rate for our ICU doctors who are having these discussions, so it might not be someone that the family is familiar with who's had the previous discussion. We had a little bit of a talk about this yesterday. I feel if we have subspecialists who are really primarily following our patients and come in when there are pivotal discussions, we're going to have family's better understanding at these different crises. I've been able to be involved and sat in on discussions. One patient strikes me particularly from a couple of these discussions in the NICU to them being moved out to our intermediate care unit where the child deteriorated, and the family was hearing these same words again, and I said, this is why I think this is different than the other discussions, because I'd had the luxury of being part of them. And the ICU attending was astounded that the family came back an hour later and said, we're gathering all of our family tomorrow. We want to take him off of the ventilator after everyone's been able to be here to say their goodbyes and then be present. So I think that continuity in those discussions and having a little bit of room for doubt. I've been wrong before. My most used line, because I think it speaks to everybody's belief system and also leaves room, is we're not in charge. And I think that really speaks to everybody's faith system. I don't presume that theirs might be mine, but I've never offended anyone by saying that. And it leaves a little bit of room for us being wrong. And thankfully we are sometimes. So what about we're not in charge? How much time do I have? I know we started late.
25 more minutes.
Oh, okay, all right. Oh, good, you're a captive audience for a while longer. So what are some of my we're not in charge stories? So prognostic uncertainty and what I call happies. And don't tell my first English professor, Doris Aegis, that I used happies because it's not really a word. But I do have, again, the luxury of following patients after they leave the ICU to the regular part of the hospital, after they leave the hospital to go home. And so we get to see the unexpected outcomes. And I come back, I circle back to the ICU with the happies, to make them happy, and also hopefully to give them a little bit of sense that maybe our certainty ought to be just a little bit less certain. So we had a 3-year-old who had been in a motor vehicle accident. We were called in actually the night that it happened, and they said, neurosurgery saw the child, said there's nothing more that can be done. The family was approached about taking the child off of the ventilator. There had actually been 2 other family members who had died in the motor vehicle accident, and I thought, why are we even asking this tonight? But nonetheless, it was asked. The family declined. And then about 48 hours later, the neurosurgeon said, this child is changing a bit on scan, and did much better than expected. And I was able to see him on the 11th floor of our hospital before he went home, and got permission from the grandmother to video him walking with his grandmother holding her hand. Now granted, he needed to hold her hand, but I brought that back to the ICU, and we had some weeping, but happily weeping nurses. And I think it is important that we have a little bit of respect for what we don't know. We had a 10-year-old recently with a near drowning episode who had a thalamic injury, which I kept hearing, thalamic injury, she'll never get better, and she was quite agitated. Ultimately, her family sent us a video of her walking out of Shepherd's Rehab in Atlanta, waving, saying, "I'm out of here." So another happy. And then we had a 17-year-old with cerebral palsy and severe developmental delay who the family just, the child was DNR, had post-form, but the family really wanted this child to get home for Thanksgiving and maybe Christmas. The staff thought, oh, he may not even survive the ambulance ride home because he was pretty unstable on BiPAP, which is a mask sealed over the mouth and nose that was providing non-invasive ventilatory support. So I went in the ambulance just in case he started to do poorly, so we could make sure that his dyspnea was treated. Our PD flight team got him home, got him in the house. His mother sent me a text picture about a week later with his oxygen saturation and his heart rate in the picture. And then about another 2 weeks later, she sent me a picture of him with nasal cannula. So he was on nasal cannula during the day and BiPAP at night. And he has lived now through Thanksgiving and through Christmas, which is what his mother really wanted. So we really can be wrong a lot of the time. Humility is important. How about the post versus hospital DNR? So when patients come in who already have a post, as you talked about, it should be reviewed. Those orders, we have a computer order entry, so the orders based on the post and based on the discussion with the family about whether any of their decisions had changed get put into the computer order entry. If a patient is in the hospital, does not have a post, either because the family has not wished to make a decision about it before, hasn't been willing to engage in a conversation, or the child hasn't been at a clinical stage where it was warranted, and we have a discussion about resuscitation status, at that point, we don't fill out the post form. We document a note about the family's goals of care, about their wishes for limitations on resuscitation, and then put the order in the computer order entry. If that child then is transferred to another facility from our hospital, is going to be able to be discharged from the home from the hospital, that's when we fill out the paper post form. And at least in our hospital, because we don't have a nice robust system like they have in La Crosse, putting it in the computer order entry allows, and putting a note that documents the discussion and the family's wishes, allows us to be a little bit more nimble, I think, about making changes and making sure that the most recent decision on the part of the family is honored. And why does that particularly matter? I think in pediatrics probably even more so than in the adult world, our families change their mind. So a child is in the ICU, is critically ill, the family's been told that the child's not going to survive, so they make a decision. Usually the child's already intubated, but they make a decision for no cardiac compressions or cardiac shocking in the event of that. The child survives the ICU, comes back out to the ward, continues to be more stable, and the family then decides that this does no longer make sense for my child. And so we need to be able to be, I think, nimble about responding to those families' changes. Also, the parents sign the post form, and even though what they're signing says that that they've had a discussion about their wishes, I've seen parents, and I don't know if you've had this experience in your practice, but that there's some trepidation. I'm signing my child's DNR order, and what they're signing, and I tell them, is you're signing that we've had a discussion about this, and I'm not the rogue doctor who thinks that I know what's right for your child, and you're documenting that, yes, we had this discussion and these are your decisions. And somehow that seems to make it a little bit easier for families, but I do find, at least in pediatrics, that signature piece can be a little bit of a sticking point. It just feels, I think, a little bit more sort of active on the part of the parent, more active than the discussion within the context of the prognosis. All right, what about unrecognized consequences? So this was a study done out of Boston Children's Hospital, and DFCI is Dana-Farber Cancer Institute. And so they surveyed staff in the medical and surgical ICU, in the medicine ICU, and in the cardiac ICU. And they surveyed 107 physicians and 159 nurses. And the questions that were asked, or three of the pertinent questions on this survey: when a child has not a DNR order in place, what does this mean to you? In your experience, how much does the care of a patient change once a DNR order is written? And in what way does the care change? So the answers were, in 66.9% of the respondents said it meant limitation of resuscitation only, which is appropriate. 33% felt that it meant limitation of other treatments. And certainly the discussion about resuscitation can lead to discussion about limitation of other treatments, but a DNR does not include those other treatments. And then comfort measures only. And I know we say only. I highlighted it in blue because I just think it diminishes what comfort measures are. So my own bias. But 6.2% thought that it meant comfort measures only, which clearly is problematic. 66.9% felt that the care changed. The physicians, in a statistically significant manner, felt that the care changed more than the perception from the nurses. It might be that the nurses are at the bedside and are a little more aware than we are. Then if they thought that it changed, they were asked how. 36.7% thought that it increased attention to comfort, and 52.1% said that they thought there was a limitation or withdrawal of treatment. The top, and so just go back to that for just one moment. So this, in addition to a couple of anecdotal experiences from two of our patients, have had us change a little bit what we do when our patients are discharged home with a post form. So we had a patient with, again, with spinal muscular atrophy who was being transferred home via ambulance, again on BiPAP, because the goal was for her to be home to celebrate her first birthday, which was happening 2 days hence. On the way home, she started to have a seizure, and her grandmother said, she's having a seizure, we need to treat it. And the EMS personnel said, well, she's DNR, we can't treat it. Ultimately, she was, and she ended up being able to be home for her first birthday. Another situation, I ran into the mom of a patient with cerebral palsy and developmental delay who had taken her child to, I think, a pulmonary appointment. And she was told, well, you don't have to bring her to pulmonary appointments anymore because she's in palliative care. And so we now send our families with a letter that I think explicitly lays out more than the ABC in the section about what the family's expectations are for other treatments. And then we put our contact information if the family needs someone to help advocate for them. And this may be making some of you feel horrified, but we feel like this is a sort of an extra step assurance that our family's goals are honored. And then we put a statement which seems like a common sense ain't so common statement, that if there are any questions about interventions.
Probably if you want to give a little time for questions.
Okay.
I don't know how far you're how would you like to end, but we need to get at least 5 minutes.
Okay. That if they have any questions about a particular treatment, ask the family what they want, or the patient if the patient's verbal and over 18. The barriers to DNR discussions in this study: unrealistic parent expectations, lack of parent readiness, and prognosis, understanding disparity of prognosis that was a disparity between physicians and parents. All right, I will. Okay, so poignant moments, just a couple poignant moments. You probably think I've already told you enough, but this is a patient that I took care of who developed leukemia at 17 years of age. I knew him or 16 years of age. I knew him for about 2.5 years before his therapy he had no curative options for his therapy. He'd had lifelong immunosuppression for a kidney and liver transplant. So I was a dutiful hem-onc fellow, and my attending said, you need to go get the DNR before he goes home. And I knew that I'd had discussions with this family. I should have done what I think you did in a note on a consult. This family has made it clear that they're not ready to have this discussion, and it really was probably inappropriate and bad for them to have the discussion. They didn't make a decision. They came, luckily they forgave me in the long run, but they came to speak at an end-of-life course at UMass, and what they said to the audience with me was, you didn't need to tell us one more time our child was going to die. And there was still a bit of heat in that even a year later. Ultimately, what happened was he developed some severe respiratory distress at home. He had medication for that respiratory distress, and his dad called and said, should we call an ambulance? This is what's going on. And I said, if you call an ambulance, this is what they're going to do. And he says, oh, I guess we have to make the decision now. And so they gave him medicine. They didn't call the ambulance, and he died at home as they wished. So it just taught me that sometimes, as much as we want people to be ready, they're just not ready until they are really ready. And I'm going to skip this one. It's sometimes the mystery of death that brings us to a consciousness of the still greater mystery of life. And I think what I feel like what I get to do is incredibly sacred, and people wonder why I don't leave feeling downtrodden. I actually leave most of the time feeling uplifted. I have a palliative care bracelet that has a disc that says heal, because when you can't cure, you can always, maybe not always heal, but you can at least always try to heal. So I think that that's important. And then when we do this kind of work, I think that we need ways to refill our vessel. So books, good food, and I'm not, I'll give you the name of this cookbook, but I'm not getting any promotional money from the cookbook. And as some of you know, I just got back from hiking and snowshoeing in Yellowstone, and I think those are the things that help me refill my vessel. But I think for all of us that do hard work and have these difficult discussions, we need to find ways to refill our own vessels. So thank you.